Okay, and I'm gonna share my screen because I have an introduction slide to make. Okay, excellent. And Amelie is still connecting. So well, maybe I'll email her separately because I don't want to start late the presentation, and maybe we can discuss. Either she can call in or we can figure out what to do. All right. Does anybody have any question? All good? All right. Let me.
Breno, be sure to introduce yourself.
I'm sorry.
your name online just says Society of Government Economists, and sometimes people want to see the affiliation, but let's make sure they know your name too.
I was more afraid to make sure that everybody could share the slide. So my name is Breno Braga. I'm a economist at the Urban Institute in DC, and I'm one of the organizers of this lunch seminar series that we have. So nice to meet everyone.
That's perfect, but tell everybody when they all come.
Oh, no, I was planning to do that too.
Righto.
So you guys can see my slide though, right?
Yep.
All right, excellent.
Yeah, that's good.
So it's 11:59. Let's just give people a few minutes.
Yeah, this is good. You're nicely well organized.
Yeah. Well, the second time I'm doing, so usually, things get better over time.
By the way, for everyone, we have an upcoming conference. Submissions are due Monday, and the conference will be April 1st. It's our annual conference. Will you mention that at the end, Breno?
That's my second slide, actually. Yeah.
Perfect.
I see some folks connecting. I'm just gonna give, until 12:01 to do the introduction. So Amelie, can you hear us now? I see you're connected.
Yes, hello, I can hear you.
Oh, nice to see you.
And I can hear you.
Yeah, do you have slides to share? Or your discussion is going to be only like via video?
Yeah, I will, yeah, just orally, yeah.
Okay,
it will
excellent.
Not take long. I have no slides.
Excellent. So when is your turn to speak, just unmute yourself, okay?
So I understand I'm the last one, right? Or you changed the...
No, you're the last one. That's correct.
Okay, all right.
Excellent, thank you. All right, so I think in order to make sure that we can finish in time, welcome everyone to our second lunch seminar. The topic today is new developments in health economics in the pandemic era. So my name is Breno Braga. I'm a researcher at the Urban Institute, and I'm also in the board of SGE. Just a few announcements before I give the floor to Seth, that is our chair. We have our SGE annual conference in April 1st. It's still going to be online. The deadline for paper submission is Monday, January 31st. So I, suggest everyone to, submit your papers. It's a very interesting conference. I also want to make an announcement about our next lunch webinar. So it's going to be on February 11th. And the title is How Climate Change Affects the World Economy and Possible Solutions. I think the email announcement is going to go either today or Monday. And last but not least, we are accepting nominations for the SG Board of Direction elections. So every year we change some of the people that have to manage SG. So this time we're electing the folks for the board of directions, and you can also see, I think we sent an email recently about that. Now I'll pass the floor to Seth, that is our chair for the section, and he's going to explain how the section goes and everything else. Thank you.
Okay, thank you, Brenda. Yeah, so I'm excited to chair this session. We have 4 interesting papers and discussants. We have 2 hours overall. I've set things up so that each presenter will have 18 minutes, and then each discussant will have up to 7 minutes. And then that should leave us with some time at the end for questions from the attendees at large, and for discussion, and for the presenters to respond. So this is AIRLEAP's 2022 SGE virtual session, new developments in health economics in the pandemic era. Well, we'll get started with the first paper here. I think these are all timely, very interesting papers. The paper 1 is COVID-19 long haulers, Democratization of Healthcare Information and the Economics of Prevention, eHealth and Rest. Julia Puaschunder is the first presenter, and my apologies if I mispronounce names here. So I'll turn it over to Julia now.
Yes, thank you so much, Professor Giertz and Professor Brenner Braga, for this kind introduction. And I do have to say thank you to Professor Areerat, Kichkha, and Dr. Steve Payson for really hosting this exciting event. So I want to speak today a bit about COVID-19 long haulers. This is research in progress, I have to admit, so please feel free to really educate me if you have more information as we all learn more about the pandemic. I want to start by making the case that pandemics, as horrible they are, they sometimes are spring feathers for lasting societal change. We can see in the 14th century Great Plague of the 14th century, that was really the beginning of better healthcare systems and hygiene standards in Europe at that time. And it was the beginning actually of the Renaissance. We saw the lack of labor really drove people into mechanization, figuring out how human power can be replaced by machines, but also values like self-determination and democracy really started to bloom after a crisis. And with this, you can also tie this back to our current times. We are still living through the pandemic. Figures of today, we can say that over 300 million cases have been reported of the coronavirus. We already can now say we had about 5 to 50% unreported cases, although I have to admit in this figure that it was derived from worldwide data, we can say that it also has a double count potentially, or it doesn't control for multiple counts of infections, and not everyone who is infected really has symptoms. But still, if you start then calculating that about 80 to 100% of human beings will have some sort of touch point with the novel coronavirus cases, and just lately as the new wave has started to emerge, we had more and more information in the news that about 80 to 100% of people will be at a certain point in their lifetime kind of have a touch point with coronavirus cases. And then there's also this information that about 10 to 50% of the COVID infected people become what is currently called as long haulers. And those are people who have symptoms 6 to 8 weeks after they still have kind of symptoms of the infection. And when you start calculating, and here I really would would embrace any input, but when you then start calculating what world population you have, and there are currently already, there's literature out that everyone will have a touch point, and 10 to 50% of those people who are infected really develop long-term issues. That leads up to an astronomous number of 0.6 to 3.9 billion long haulers worldwide, and that comes up to 2 to 12 times the size of the US population worldwide, or 27 to 166 million in the US population. The good news in this devastating news is there currently it's not so clear what forms these long haulers. On the one hand, it seems to be kind of organ damage. There is this argument it might be a remaining viral load that's still in the system that is simply progressing, and it takes some time until it clears out. But there's also this idea it could be an overshooting of the immune system, like in Lyme disease, that you have lingering symptoms. There is the hope that if it's something related to an overshooting of the immune system, that it might wane over time. And we already see in real world data that around 18 months seems to be a recovery period. So in a normal distribution, that around 18 months seems to be a mark where people really are able to get balance back into the immune system. It seems to be that these three overlapping clusters of symptoms are comprised or show that over 200 symptoms can pop up after a coronavirus infection, and we already now see in data around 70 to 75% of these long haulers are actually female, in the median age of 40 to 42 years old. What we now see from this trend is what I call a democratization of healthcare information. We not only have an argument and a debate about equal access to medical care in prevention with the vaccination that is currently, there are currently all these debates about how to give access to quality healthcare. The TRIPS agreement that was drafted or pushed for in the 1990s is really relived here again. We have this realization that no one is safe until everyone is safe, so a classic common goods problem. But some countries simply do not have as good access to affordable healthcare, and legal law and economics ideas can really help that we grant access to affordable healthcare. Telemedicine is really booming, especially when you think that people are, it's for the very first time that people are urged to not come into a hospital when they are overfloating. So we do have this opening up of access to healthcare in the medical area that is really e-driven. We do have also with the long haulers this trend of online media information gathering. We saw in the long haul survivor corps, but also several other groups on Facebook. People started exchanging information, uploading information, which is this novel trend that people really do report their symptoms online and try to find solutions quickly together. They fill out surveys, and they see themselves as citizen scientists who really inform the government and try to craft this or navigate around this novel phenomenon together. We also see big data drives. The EU is trying to push for a fifth freedom of data incentives to share information. So on the one hand, we have this democratization, but then on the other hand, we also have this revolution in preventive care. We see that people have moved away from cities, a de-urbanization trend, and with the realization that the trajectory of the infection leading to a good outcome or a harder outcome, really depending also on preventive care, we see a drive towards people trying to live in the community in harmony with the environment. We see this also in architecture. We see biophilia designs. People want to have natural environments around their living spaces. We saw this revolution of sustainable clothing this year. People say the major breakthrough in the COP27 was this idea that fashion, which is something that every human being on earth has to somehow make decisions on a constant basis, can really be also a revolution if we start integrating more natural resources in fashion and not are using 700 gallons of water for one bleaching of one white t-shirt, for instance. We also see in the medical sector, and especially with the long holders, this importance of a healthy nutrition that seems to be some of the cause. External influences and also your nutrition seems to be calming down some of these long holding issues, especially in female that seem to have some kind of hormone imbalances. Nutrition seems to be these days really the key to help long holders. We also see governmental reforms. Not only the corporate sector is thinking more about healthcare than ever before. Liability issues are on the minds of employers. They really have to start competing over people who want to work together in a cramped building. But we also see governmental pushes. For instance, there's in Europe this Prevention Act where the government really subsidizes corporations for preventive care at the workplace, so people get some time off to play sports together, and there seems to be this push for growth lies now in learning to prevent spreads of disease in the workplace. On the third level, I argue that we see a revolution of healthcare monitoring and tracking. We already saw before the crisis came down, tracking apps, trend analysis, genetic risk analysis being really at the forefront of medical care. But now we also see Bluetooth cartographies that can really show where medical devices in a very speedy real-time solution be at the forefront. We also see it in the prevention. So apps are starting to measure viral loads. It's not as safe as other solutions so far, but there's definitely also an interesting innovation coming out that we will see hopefully in the future, more tracking of the environment and seeing how that really plays out. On the forefront of long haulers who often have waves of uncertainty. So sometimes these long haulers seem to be a few days fine and then a few days really weak. We potentially will see more artificial intelligence and robotics filling these gaps of uncertainty. And in the entire economic sphere, I do expect that we will see more thinking about the ethics of inclusion, how to deal with waves of people being debilitated and then the next day functioning. We hopefully see also an opening of economics for thinking about how to be more inclusive and really include all different sorts of personal states in the economy. We also saw at the World Economic Forum talk by Janet Yellen about how growth is now more inclusive than ever. And so I expect to rise. Just on the eHealth side, I want to show one data point that I find really interesting here. So I mapped two different indices. The one is artificial intelligence, and the other one is corruption. So corruption is usually measured in artificial intelligence, corruption is usually measured in an index of transparency, the corruption perception index, and here you see the spread all over the world of corruption. And then I also plotted global connectivity. And when you plot this together, you find actually a highly significant positive correlation of freedom from corruption and global connectivity. So you can make this argument that anti-corruption comes out of corners, or artificial intelligence blooms in corners where there's not so much corruption in the world. And when you now learn from this, for healthcare, you can really say that healthcare could be via the portal of artificial intelligence, could be hopefully in corners of the world that are good on artificial intelligence and corruption, also lead the way in giving access to affordable healthcare via artificial intelligence solution. Market capitalization is very high in the US, so potentially a combination of artificial intelligence solutions and anti-corruption and good healthcare will potentially be an asset for the future of the US to lead the world. And the last argument that I want to kind of leave you with is healthcare will potentially play a major role in future economic calculus. We potentially have to do the multiplier and see how healthcare really plays in. With the long haul trend, we will also see more and more that growth will have to become more inclusive. And here I want to just leave you with, currently we live in a time where we have about the largest amount in healthcare spending coming in the US, but also in Europe, that is also pegged to green and sustainable solutions. We have in the US the Green New Deal that is currently estimated to grant about 900 billion US dollars into the economy. We have in Europe the European Green Deal, and together this could kind of incept a new renaissance in the post-pandemic era in which we will hopefully also see future trends in which we think about economics not only in terms of maximizing utility and efficiency, but also an appreciation for the economics of inclusiveness and inclusive growth. And with this, I hopefully I was somewhat in time and look forward to questions and answers.
Okay, thank you, Julia. That was just about perfect. So you finished within time. Great. Now we'll turn it. Excuse me. We'll turn it over to our discussants, and so our discussant here is John Muahi from the University of Wisconsin. And John, you have up to 7 minutes.
Great. Thanks, Seth, and thanks, Julia, for your presentation and your paper. The reality of what you have studied came clear to me when I was getting ready to teach a class in October, and I went up to the whiteboard and I had that really pungent whiteboard cleaner to spray, and I asked the students, I said, I hope you don't mind. And one of the students said, oh, I don't care. I haven't been able to smell anything since December. And it was at that moment that the reality of the long hauler effect became clear to me. So I really appreciate the topic you're talking about. I read your paper in a couple different ways. One was descriptive of where we are now. The interpretation that I'm going to carry through my remarks, though, is that your paper, I think, sets up an important research agenda. for topics that we would, I think, be well positioned to learn a lot more about. And I have about 6 of these topics. I'm going to go through them very quickly in the interest of time. But this is just what strikes me as important. The first one is, if we're going to understand something about this long hauler phenomenon, we have to think about what is the population of long haulers, and that's going to be hard. The manifestations are heterogeneous. The definitions certainly will change over time, like they do with high cholesterol and hypertension and things like that. But understanding what's happening means trying to figure out what this population is and what's happening to them. And we might be challenged because that could be a moving target. The second part of the research agenda I think would be interesting is to understand how these long hauler COVID effects affect the time use patterns of people that are affected. You paper emphasizes phenomena like rest and slowness. And it would be interesting to see how that gets manifested in just the day-to-day patterns of the way people affected, assuming we can define who they are, how their day-to-day patterns of time use are affected, labor market participation, sleep, et cetera, et cetera. So a time use part of the research agenda. A third part of the agenda I think would be interesting is to, and I'll combine all this in some ways under telehealth or electronic medical records, but learning about the sort of the value of these technologies, the cost effectiveness of these technologies. Are people being made better off, for example, because of telehealth encounters compared to some alternative? Is the quality of the information, for example, in an online forum, good quality information? Is it useful information, or is it sort of an echo chamber problem? I seek out the kind of information I want to hear and avoid the kind of information that, even though it may be good for me, I don't necessarily want to hear it. For some information sources, I'd say it's easy to imagine that people would be actually better off in the long run not hearing certain things, even though they voluntarily seek it out. And one other aspect of the sort of electronic, however you want to characterize it, the role of technology here, is there too much information? Think of self-monitoring, for example. I've got my smartwatch on, and now how do I know if some detected change in my heart rhythm is a sign of a problematic arrhythmia or just a natural transitory change in my heart rhythm? So we run into these big problems of false positives, things that we really don't need to worry about, but that because we're monitoring all the time, they're being signaled to us. So more information, yes, but is more information always good? Question mark. One more topic, going to electronic medical records. I here in Madison, Wisconsin, 7 miles up the road from where Epic Health Systems exists, the largest electronic medical record vendor. So we engage a lot. And one of the things we've come to learn is that just because data are in an electronic medical record doesn't necessarily mean that the data are high quality. I walked into my clinic about 6 years ago. My provider brought up my Epic record and they said, "Oh, I see that when you were here last year, you weighed 242 pounds. And I said, I don't think that's right. The data in the electronic medical record were just simply miscoded. I go up and down like everybody, but I've never been in shouting distance of 242 pounds. So relying on electronic medical records as a source of information, absolutely, there's a wealth of information out there, but how good is the quality of the data, and are the data informative for the relevant decision makers at hand, the health systems, the clinicians, the patients? One size doesn't necessarily fit all there. So I see that I'm running out of time. Let me just rewind a bit and say, I think you had an ambitious paper. I think I learned a lot by reading it. I think it describes a lot of where we are now, but I also think we could read your paper very beneficially as saying, here are some areas where I think we should dig in and attempt to learn a lot more. So thanks for the opportunity to discuss the paper, and I'll send it back to the chair.
Thank you, John. Appreciate that. We are moving along on schedule. I think we'll hold off comments and other questions until everyone's presented. We'll go on now to, let's see, to paper 2. Paper 2 is Assessing Communication and Compassion Fatigue in Healthcare, a case study of treating amyotrophic lateral sclerosis, ALS. Our presenter is Deb Dwyer of Farmingdale State College. All right, I'll turn it over to Debra now.
Thank you. And before I share my screen, I just want to introduce myself. I'm a health and labor economist, and I want to share, I thank Julia for her comments. I do see the pandemic as an opportunity. It's been a difficult time, but it is an opportunity to do better. And she took it from a big picture approach, and I'm going to narrow it down into a more micro approach. So let me just share my screen. Okay, can everybody see that?
Yeah, good.
Okay. So, and bear with me if my internet gives out because it's been very shaky. So my co-author is also on the call, Lorraine Danowski. She's a registered dietitian who works in an ALS clinic. So she has her PhD in health sciences research, but she also works directly in an ALS clinic and is instrumental, obviously, and first author on this paper. And so she day-to-day meets the significant needs of the ALS population, and I'll talk more about that later. While the work uses ALS to study the potential gains from operating in a one-stop clinic environment, it applies to any patient population that requires intense treatment from diversely trained medical experts to alleviate both physical and emotional pain that involves both themselves, the patients, and their personal caregivers. Much of the literature focuses on cancer patients in hospitals. The contribution of this work will shed light on the value of a team approach to healthcare in an outpatient setting, on maintaining the effectiveness of the healthcare workers who are at risk of compassion fatigue from not only providing critical care that is much needed, that can be physically and mentally exhausting, but to witness suffering that can take a toll emotionally. The pandemic has only increased the risk to such healthcare workers, as we've all heard. We were not terribly prepared in many ways for the COVID-19 pandemic. Moving forward, designing systems of care that are more efficient can improve the well-being of patients, their families, and providers. The focus of this work is on the provider without whom the well-being of patients and their families cannot be sustained. So why teams? This paper is about a proposed change to practice that has already been encouraged by policies, such as the Patient Protection and Affordable Care legislation passed back in 2010. The legislation provides financial incentives to models that coordinate patient care across the various experts involved in the production and maintenance of that patient's health, and technology and the electronic medical record has been a big part of that. It is recognized there are efficiency gains to be had from coordinating care for a variety of reasons. First and foremost, it minimizes the risk of harm that may come from duplicated services or missing information vital to the patient's well-being. Second, it shares the burden of care across medical personnel that are at risk of compassion fatigue from treating terminally ill or severely disabled patients and being strong for their personal caregivers. There are a variety of coordinated systems that range from virtual communication through the electronic medical records to a one-stop shop where patients can have all of their needs met in one place and at one time. Sorry. A more efficient approach to caring for the severely ill will not only prove to be cost-effective in the delivery of healthcare services, but also generate benefits related to economic growth and stability that comes from stronger human capital, which Julia also alluded to. Furthermore, efficient care creates more care that can better meet our equity goals of extending access to all. So Webster defines compassion fatigue as the physical and mental exhaustion and emotional withdrawal experienced by those who care for sick or traumatized people over an extended period of time. Tim Jarvis from the Oprah magazine wrote this in 2009. Unlike burnout, which is caused by everyday work stresses, compassion fatigue results from taking on the emotional burden of a patient's agony. The anecdotes we hear about the awful decisions that needed to be made treating the severely ill hospitalized patients with COVID who had only a low probability of survival predicts a rise of compassion fatigue among healthcare workers. The lines extending outside the local walk-in clinics place all healthcare workers in such facilities at risk. Thus, Dr. Barry in 2021 states that COVID-19 has placed a tremendous strain on a workforce already at risk for burnout. Even prior to COVID, emotional exhaustion, depression, and suicide among healthcare workers were already staggering. Now these rates are even higher. This is a crisis, as the healthcare system will fall apart without a workforce that is physically, emotionally, and spiritually healthy. Given the need for cost reduction and improved access that precedes the enactment of the Affordable Care Act that was passed in 2010, coordinated care models have been developed to minimize errors and reduce transaction costs of delivering healthcare across disciplines. The patient-centered care approach and the accountable care organization model are two outcomes of such initiatives. These types of initiatives are not only encouraged under the Affordable Care Act legislation, but incentivized with subsidies for doing so. These are general terms for coordinated care, and the details in implementation vary considerably. We will turn to the literature on how one would define types of teams that exist for coordinating effort. One of the contributions of this study is to focus in on the outpatient one-stop clinic, given it has great potential to improve efficiency, given the gains that come from a more coordinated system. Part of the cost savings come from a reduction in ER visits and hospitalizations. The literature has primarily focused on the value of coordinated teams in an inpatient setting. Henderson finds a positive impact on the likelihood of contracting hospital-acquired infections, which is a common adverse outcome from an accountability failure that might stem from insufficient patient coordination. Other studies have examined team impact on heart transplantation and malnutrition patients. Many studies, including that of Kola et al., have examined team impact on cancer patients. Cancer patients vary in their remaining life expectancy, but for all of them, the treatment plan is intense and involves many disciplines, making it a good disease for study. There are significant potential efficiency gains in the treatment of patients with diseases like cancer. We will see how ALS is another condition that has the potential for significant efficiency gains, not only on the demand side, but on the supply side as well. The literature to date varies in the type of coordinated care in the study, but many interchange the terms with little consideration for how they may differ in operations and subsequently outcomes. In an effort to more formalize the notion of coordinated care from the general categories of patient-centered care or accountable care management, the terms multidisciplinary and interdisciplinary have come about to emphasize coordinated care among diverse areas of expertise within healthcare. However, the terms have been interchanged. We will see that the distinction between these two specific types of teams, multidisciplinary and interdisciplinary, can be analogous to the two-party system philosophy of how strong the central government is in the process of coordinating decision-making. So the multidisciplinary team is the one with the more centralized governance structure. A physician, in the case of ALS patients, typically the neurologist, oversees operations and ensures the coordination of communication disseminated where it needs to go, while the team health providers autonomously do their thing to handle their specific part of patient care. For example, the nutritionist will design the diet plan throughout the stages of the disease, working with information provided by the neurologist regarding the progression of the disease and its impact on swallowing. The physical therapist will also develop and implement rehabilitation plans as the disease progresses, being fed information regarding simultaneous care required in the disease progression that may affect mobility and rehab needs. The interdisciplinary approach, on the other hand, is one where the nutritionist, the physical therapist, the neurologist, and all other caregivers set aside time to meet on the patient's care and go over the treatment plan and how each piece fits together in terms of the timing and the type of care. So they do this simultaneously. Sometimes there are overlapping roles. In both approaches, information needs to be shared regarding who will implement that part of the plan to avoid redundancy that can be financially and medically costly. So one of the contributions of this work is to consider that not all clinics or teams will fit into the extremes of the multidisciplinary or interdisciplinary model. They may adopt attributes of each. When forced to choose between the two types, members of teams that do not fit neatly into one or the other are more likely to be inconsistent in their responses, creating noise. In this work, we will allow for a third option, the hybrid. The survey design allows for future work to go further into the attributes of the team, but this initial study merely examines the effectiveness of the two team types after the noise of the mix is removed from the sample. Ideally, the hybrid represents a team approach that combines the attributes of the two types into a model that is specifically designed to meet the needs of that institution. If that is the case, the hybrid approach will come out ahead on the evaluation. Alternatively, the hybrid results will be noisy given more heterogeneity among those classified into that team type. So why ALS? Because of the ALS Ice Bucket Challenge that you may have heard about, a lot of attention has been given to this disease. The patient declines quickly and the need for assistance is dire. Patients cannot engage independently in activities of daily living, requiring home health aid assistance. The care involves multiple medical appointments on a regular basis to monitor the disease and its symptoms. A one-stop shop to a clinic that would allow the patient to see the neurologist, physical therapist, occupational therapist, social worker, speech language pathologist, physical therapist, respiratory therapist, and nurse within a 2 to 3 hour time frame, reduce the time and transportation costs of the patients and their caregivers. It also allows for the coordinated care. By working as a team, not only are the patients more likely to experience a cohesive treatment plan, but the workers are less isolated as they face difficult decisions. So in sum, the contribution of this work is we use a survey design that provides the definition of team type and allows multiple healthcare providers to select the type of team they operate in. We use a stronger indicator of the programs we are evaluating than the previous literature. We are the first to do this in an outpatient setting, as far as we know, where very debilitated patients with ongoing care needs spend most of their time. This is a first step toward a better understanding of the importance of the team design. Future work will focus in on the attributes of the team as well as how they relate to measurement error and the self-report of team type across respondents within a clinic. So one of the peculiarities on the supply side of healthcare, I'm talking fast because I have a lot of slides, sorry, is the dual components of the provider in the provider's objective function. Providers, like all producers of goods and services, seek to maximize profit. They must also take the Hippocratic oath to do no harm and put the well-being of the patient first. In this case, the well-being is with respect to the quality of their healthcare production. The provider acts as an advocate and agent for the patient, thereby including the welfare function of the patient in their own. In the case of ALS, it is the patient and their family that is embedded within their objective function. All agents are producing services to improve the functionality and quality of life of the patients and their families. So that is the output. What is relevant in predicting the outcomes for the providers and their patients are the production technologies available, the attributes of the patients, the attributes of the team, and the attributes of the market. In this work, we will control for the attributes of the patients, clinic, and team. The attributes that we focus in on in this study are the attributes of the team type, on the emotional health of the team members. In other words, we've examined the relational coordination of the, in other work, we've examined the relational coordination of the team, but we bring that in this work as well. Both will affect the quality of care produced by the team toward the end goal of improved health for patients. 2 surveys were designed to collect the data. One collects data regarding the team attributes, including relational coordination, and ProQol, which is the validated index of compassion fatigue, and discipline information. Another survey collected the clinic level attributes. A pilot study was conducted in person at a large clinic that was then omitted from the study. The pilot provided valuable information to make the survey more efficient. Qualtrics surveys were sent out to all 110 US ALS clinics through the Northeast ALS Consortium with 2-week follow-up, and that's their professional organization, in hopes that we'd get a higher response rate. The compassion fatigue survey is called ProQol and is a validated instrument for measuring the 3 components of compassion fatigue. Compassion satisfaction measures how satisfied you are in the job and asks the respondents to rate statements such as "I am happy" or "I get satisfaction from being able to help people." Compassion burnout measures weariness that occurs gradually over time. An example of this is "I feel overwhelmed because my caseload seems endless and I feel bogged down by the system." Secondary traumatic stress measures a more acute, severe episode of trauma, such as "because of my work, I have felt on edge about various things and I feel trapped by my job." A higher score on compassion satisfaction represents low compassion fatigue, while a high score on the other 2 indicates the presence of compassion fatigue. One of our contributions is to take what Corner defined theoretically and tested empirically. Unlike the literature that tends to measure coordination by a dichotomous indicator of whether any coordination system is present or not, in this work, we specifically define the terms inter and multidisciplinary in the survey and ask respondents to categorize their team. We allow for a hybrid option, given it is possible teams do not fit neatly into one box or the other. A neither option was also included. Given we were surveying one-stop shops, it was unlikely that any respondent would choose neither. The hybrid team option allows for a cleaner indicator of the two main types of coordinated teams by removing unobserved heterogeneity that might exist when respondents who are on the fence are forced to choose. For example, two respondents in the same clinic that has components of each team type might respond differently, creating noisy indicators. One of the limitations of the study is that despite the involvement of the professional organization NEALS, the response rate was low. We have data from 37 of the 110 clinics, or 34%. The response rate among individual respondents was lower, but that is less of a concern than having clinic level representation. Multiple responses within a clinic allow for analysis of measurement error and self-reports, as well as discipline-specific perspectives. We do have 110 respondents that completed the survey. Neurologists tend to be the more likely leader of a team when there is a governance structure that allows for that. For that reason, it is not surprising that the highest response rate was among neurologists. A majority of the respondents classified their clinics as hybrid, 52%. 43% of clinics are ultimately classified as hybrid, 33% as interdisciplinary, and 18.5% as multidisciplinary. So there's the response, how the respondents define it, and then ultimately in the end, how each clinic is defined. So 43% ends up in hybrid, 33 interdisciplinary, and close to 19 multidisciplinary. A majority of them are large clinics. So this is the first regression. It's a model of compassion satisfaction, compassion secondary traumatic stress, and burnout. So separating out the three team types, the three components of compassion fatigue. We also did some factor analysis on this, and it came out with these three mutually exclusive categories, which gave some validation to our data and our index. The omitted category in a regression model of the components of compassion fatigue is the hybrid model. So relative to the hybrid model, the pure interdisciplinary and multidisciplinary teams experience less compassion traumatic stress, with a stronger effect among those reporting the multidisciplinary team. When it comes to compassion burnout, the multidisciplinary team outperforms all other types, with the score close to 6 points lower than the others. The average tends to be around 50. Because in our initial analysis, the indicator of discipline was significant in one of the models, this regression allows for differential impact by discipline. Not surprisingly, the clinical social worker who is responsible for guiding families through the realities of the impending loss of their loved one experienced the most compassion fatigue in the form of reduced compassion satisfaction and higher rates of compassion burnout. Again, the interdisciplinary and the multidisciplinary team members score better in terms of experiencing compassion fatigue. Multidisciplinary teams again outperform the interdisciplinary teams in the burnout component. Burnout has more to do with gradual increase in weariness as opposed to a sudden onset of trauma, as in the compassion traumatic stress indicator.
So excuse me, we're running low on time, so try to wrap up.
Okay,
soon,
thank you for that. All right, so we did a couple of more models to just strengthen our findings, the robustness checks, and they work out. We did a model predicting coordination because I think that's important. I wanted to give you some sense that the multidisciplinary teams turn out to be more coordinated than all of the others. So our work contributes to the limited work on assessing outpatient and ambulatory healthcare teams. It motivates further analysis of effective coordination and its impact on healthcare worker well-being and ability to care for patients. Efficiency is key, particularly during a pandemic. The findings suggest that coordination can improve provider effectiveness, which would, as an important input to health production, naturally increase population health. The data collected includes cost data as well as more specific information about the attributes of the team, such as the ability to provide wheelchairs in-house versus the need to outsource, potential measurement error, and the key variables of taking advantage of multiple responses within clinics. The response rates are low. Public information on the omitted teams might help to shed light on potential sample selection bias, allowing for some correction in interpretations. And thank you. So I will stop sharing now.
Great. Thank you, Deborah. That was great. So just a note, I will direct message the presenter with updates when we're getting low on time. I know it's probably very difficult to be presenting and also to monitor that. So I will also try to intervene and just give you a verbal note when we're getting close to the end there, but everyone is doing a great job in monitoring the time on their own. So thank you. Now we'll hear from Steve Payson from the University of Maryland for his comments on this work.
Okay. Okay. Can people see the screen? Yes.
Yes.
Okay. Oh, great. Okay. And you can hear me? Good. No, I thought it was a very, very interesting paper. It's such an important topic. When I first started reading it, I know that Deb mentioned, in her presentation, that's Lou Gehrig's disease. So people at my age tend to remember it that way until, Steve Hawkins also, made people very aware of it. So it's a really horrible, debilitating disease. So here's some of my comments on it. Okay, so what I liked about the paper, I liked a lot of things about the paper. So I think it selected a very important and extremely relevant topic, especially in light of the COVID that the whole world is going through now, because you're facing the same kinds of things of compassion fatigue and burnout among health workers. So it's a really important topic in that regard. And it presented a strong case for why the study was important. I thought the paper was well organized and it had very good explanations of the objectives and what the study was actually doing. I thought it was very clear. So that's always enjoyable to read an economics paper that you can understand. And I thought it was very honest in its discussion of the limitations of the findings, such as the limitations encountered due to low sample size and low participation rates. So it's just a first step in research and things like that. So the hope, I guess, is to get more samples, more observations, so that the same kind of research can be built upon. I think that would be great. So that was what I liked about the paper. So I have some suggested areas for improvement of the paper. There's different types of teams that are identified. There's on different types. There's compassion and burnout, etc. Might be best viewed as psychological effects, which are surely important in their own right. So these are kind of the main effects, and I'm thinking of them as psychological effects, pretty much, especially when talking about emotional health of the workers. So I think within the context of a paper being a study in psychology or occupational health, it's pretty, in my mind, I mean, I'm not an expert in this field. I had it as an undergrad, but I mean, it seems to be pretty complete in this regard. But within the context of economics, there's several economic effects that are touched on in the paper. And I think if there's potential for these economics effects to be built up more in a sort of, an economics paper that has more measurement of them or more discussion of them. So to me, when I looked at this, I'm thinking, okay, well, what are the, economic effects going on here? And they are mentioned, but, I'm just saying that they could sort of be mentioned with a little more detail, I guess, in terms of economics. So one is obviously the benefit to the worker, especially from, multidisciplinary teams in terms of their psychological health. So, so one question is, I don't know if this could be answered, but one thing that comes to mind is to what extent can this actually be measured? I guess the survey measures it, the a pro-qual survey measures it in terms of, some kind of scales and things like that. But how does it compare, in the bigger scheme of things in people's, psychological health, I guess, sort of, relative to other things or other situations. So there's a benefit to the worker. It's kind of like, in addition to their salary, I guess. There's the worker productivity, which is mentioned several times in the paper, how effective their work could be. The worker productivity, even in the best situations, is hard to measure. But maybe if there's something that could be, maybe anecdotally, something could be described more about how that it takes effect. And there's always the utility and disutility of labor. So how much it would cause them to, if we had multidisciplinary teams, that reduces compassion fatigue, how much would it cause them to like their job better? They may be less likely to quit, especially in the, the age of the great resignation, and how they might maybe more likely to tolerate a lower wage and that kind of thing, which also, I guess, relates to labor supply. I'm sure there's, I'm not sure, but I would guess there's a shortage of these workers because of all the difficulty, in the job. So maybe by making workers enjoy their job more or dislike their job less, that you'll have more of them will stay on the job. And then so you have these three sort of categories of benefits. This is just the way I'm looking at it. You have the benefit to the worker, increased productivity, and the worker happiness. Utility, I guess there's a lot of correlation between one and three here.
Excuse me.
Oh, one more minute? Oh my God. Really? I thought I had 7 minutes. It went fast. Okay.
Oh, yeah.
So given the above marginal benefits, then the question is how much would, the cost be, and whether we can sort of compare it from benefit cost analysis. So I'm glad I gave you guys these slides so you have a copy. So if I don't go through it all, I can. Okay, so just real quick, suggested areas for improvement. So I'm looking a lot at the data, additional background on the math involved, could better enable readers to interpret the results. So I look at these things and I try to understand what's going on, what the variables actually mean, how they're measured, that kind of thing. So I was looking through the paper and I thought, oh, it'd be nice to have it at least an appendix, just laying out the equation that was regressed and how the variables were defined. So for example, you have a minus 6.63 coefficient here, and you got compassion, stress. So does this mean it's a reduction in compassion? So simply the sign of these effects, the reader has to kind of like think about, so it would be clearer if it was sort of laid out in an appendix for the data hounds like me to just dive into and understand what's going on. The same thing with these, it's like discipline. I don't know what that is. I don't know how many choices there are for that, whether it's a binary choice, so what all these dummy variables, or categorical variables, I don't know how they're actually defined in reality, that kind of thing. And the scale effect also, I'm just wondering, what does this mean for it to be -7? I mean, out of what? I think there's hints that the scale of the test ranges from 0 to 100, but I'm not, sure if that's actually true and what that means in terms of, the magnitude of these things. There's low R squared values. So there's, questions about statistical significance, but that's understandable given the low sample size. So, like there were 110 observations, but only 13% of them were with multidisciplinary teams. So that suggests 14 total observations, if I got my math right, for these multidisciplinary teams is like the big player. It's the big idea that the paper is about. So the big idea about the paper is about the results are contingent upon 14 observations, for such a regression that has so many variables, so it's, but we say that we need a bigger sample size. So I probably run way out of time, so
okay, yeah,
sorry
thank you,
about that.
Steve. Thank you.
Yeah,
Appreciate the
you're
comments.
welcome.
During the discussion period, depending on things go, maybe we could revisit some of these issues that it sounds like Steve still has some other
No,
things
I'm
that
done
he,
with my slides. I'm good.
Okay,
All
great.
right, thanks.
Thank you, Steve.
You're welcome.
We'll turn it over now to Areerat Kichkha. The paper she'll be presenting is, let's see, exploring social bias inherent in healthcare models. And so I will turn it over to Areerat, and she will have her 18 minutes. All right.
I
Is
thought
Areerat
Brian
still-
is before me.
Okay, great. Thank you. Great.
Okay. Will Brian go first or what? All right, go ahead. Okay, sorry about this.
Okay. Yeah, I can see your screen.
We changed the order of the presentations.
Right.
Oh, let me see.
Okay.
Okay. I think, yeah, I'm sorry. I think I went out of order here. I apologize. If you're okay, you okay going on, Areerat? Yeah.
Okay, I could go
Yeah, I
ahead.
apologize. That was my fault. I went out of order. So I'm sorry for throwing you off.
Would that be okay, Emily? Okay. All right. Okay, thank you, Seth, and hello. Thank you, Seth. Sorry, I need to.
Yeah, I think it was my fault for going out of order here. So I apologize.
Okay, so thank you, Seth, and hello, everyone, and welcome to my presentation. My presentation will explore bias, social bias inherent in healthcare models. When I speak of social bias, I refer to demographic bias occur when the training data is reflecting a certain demographic over another, and biases can aggregate from imbalanced demographic data to modernization processing. Thus, social bias can increase risk of inequality in healthcare management across socioeconomic populations. This presentation will explore social bias inherent in healthcare models. I have slight change in the title just to reflect the finding. And so the presentation will use a case study to explore the social bias inherent in applications of machine learning diagnosing incoming patients at the ICU. Lacking of medical history in some patients create uncertainty on the energetic metabolism, such as glycemia related to diabetes. So we will use machine learning to train the data to classify whether patients are diabetics. Okay, so let's explore the data. We use MIT Sclerosis data set, which used in WIS 2021 datathon. So I could take advantage of the award winner who thoroughly explored this data set and select light gradient boosting machine classifiers without hyperparameter tuning in handling missing data by using the raw data as is with no imputation. I will follow this. The good thing is also without imputation or doing any feature selection may reduce some technical bias. And also hospital with lack of funds could gain insight by using this machine learning model, because the model can perform with limited data and can perform quickly without using a lot of resources. So you could see a lot of missing data in the data set. And with that, if there are also imbalanced data that stand in some demographic data, not a lot in the gender, but you could see imbalance in ethnicity. And for age range, I use the American Diabetes Association to classify the age range, and there would be some discrepancy there also. The method, as mentioned earlier, that I will use like gradient boosting machine classifier with minimal hyperparameter tuning, and train the entire data set. And the result, I got AUC score of accuracy of 0.785, which is kind of acceptable, but not as excellent as the winner. But the main point is I want to go to exploring social bias. So I would take this as acceptable models. Then we would look at predicted value, and then to indicate the true positives, true negative, false positive, and false negative from the prediction, and calculate false positive rate and false negative rates as function of subgroups. So I will look up these rates for each subgroup. And then we investigated social biases. So these are the result of the rates. And in discussion, we see that the social bias exists as the false negative rate and false positive rate of some demographic vary, whereas non-existent of social bias would have similar rates within the same demographic. For example, in gender category, there is not much difference in false negative rate or false positive rate. And we can say that there is a low bias in the gender category. But when we look at the false positive rate and are higher than false negative rate across the board. So it seemed that for some reason, it would do more of false positive in the prediction. This only except the 1844 age group that they have the opposite. And for them, the false negative rates are higher. And so in the ethnicity group, it seems that false negative rates are low, where false positive rates are high. In the group of in most group, which include Hispanic, African American, Native American, and also others we don't know, the unknown. Only Caucasian and Asian that they are not wide range of the false positive and false negative rate. But Asian did have high false negative rates, which means that they could misdiagnose as non-diabetic when they have diabetes. And in terms of policy implication, the effort, there's a way to try to lower the social biases. normally we say, okay, let's bring awareness to everybody. But the main thing is we have to have the quality data to reduce the bias in modeling. So that's something we probably would want to promote. In addition, each hospital has different demographic, and so model should be customized to the characteristic of the organization. And at the macro level, instead of doing auto guessing, would it be better to try to get individual to do more preventive care or checkups so that we have the data. Okay. And one notable thing, I did some feature importance, which probably might be difficult to see here, where age is one of the top 5. And another thing is BMI, where BMI right now doesn't look like social bias, but I wonder whether that also linked to ethnicities, and where ethnicity shows some biases, but didn't show on the feature importance. So in conclusion, that social bias increases risk of inequality in healthcare management across socioeconomic population. Biases can aggregate from imbalanced demographic data through modelization processes. So this study is still preliminary, but as a step to improve the social bias condition. Much effort is still needed to contain and monitor social biases while deploying machine learning for healthcare management. That's all. Thank you.
Okay, so I'm discussing the paper. I start to Seth, we're okay. Okay, thank you, Areerat. Thank you for organizing this really excellent session. And thank you for inviting me. I want to say I learned a lot from your paper, but this paper does not really exist. It's very preliminary, and I only received it this morning. But nonetheless, the topic is of great importance. I was not even aware of that. And the few comments I want to make as you progress along with your paper is explaining exactly what a social bias is. It's not clear that people understand. And it's not clear why this is inherent in healthcare. If it's, so the way I understand it is that somebody responds in a way that can be misleading, maybe. I'm not even sure. But how can this happen? The questionnaires are, designed usually foolproof. And when it goes to diabetes, we have certain scales, we have numbers, we have ranges to classify people and their, stage of diabetic stage. So I'm not sure how this works. So it would be a great improvement to start from the beginning and say what is the social bias and why is it inherent in healthcare research. And also explain machine learning. I know it's very trendy. It has become, the top sought field or specialization over the last 5 years. But still, there are many hiccups. There are many issues with applying machine learning, and often we get erroneous results. So it would be also good to explain how this is, this will improve if it improves, or is this your question? That's the other question, is the issue of your paper how machine learning will improve an inherent bias in this research. And from what you send me, the little 4 pages of a paper, it's full of the acronyms, and I'm getting really lost. Although they're explained in the beginning, by the time you go to the 4th page, you've really forgotten what they stand for. So you may have to find a way to explain it in a way that people don't lose the understanding of all the acronyms. And yeah, your very preliminary results look good, look encouraging. And I stop here. I wish you well. I would like to know more when you have more results. Somehow I cannot hear Seth.
Seth, we cannot hear you.
You're talking to someone, but we cannot hear
All right,
you.
yeah, so I'm sorry. Thank you, Amelie. That was great. I appreciate that. And we'll look forward to hearing more about this topic in the future, it sounds like. We'll turn to what should have been paper 3 now, improving statistical inference in health economics. The presenter will be Brian Sloboda of the University of Phoenix. Brian, if you're there, you can take over now.
Yeah, I'm here. I'm just getting ready to upload my presentation.
Sounds good. And then following that, Rolando Santos of Lakeland Community College will be our discussant.
Yes. Anyway, so here we are on Friday afternoon. It's basically improving statistical inference in health economics. It's probably a bit more broader than that. It's looking at, the use of p-values and the issues surrounding all that kind of usage and how it could be abused and misinterpreted. So, and it kind of crops up a lot in health economics as well as all areas of economics, and as a matter of fact, all areas of social science for that matter, and even business. So this paper provides an overview and it also provides some alternative remedies. I have to apologize in advance. I'm losing heat at home, so I might stumble a little. So I apologize in advance for that. But anyway, and then so the research question for the paper is going to be, what are the quantitative approaches that researchers should take to make them feel pretty reasonable if their results are really based on the econometric evidence that is likely to improve policymaking. So everything in economics and business and all the other social sciences is about how can we improve things, or our policymaking rather. So how do these quantitative approaches will fit into the framework for practical significance versus statistical significance? And the big thing is everyone thinks they're the same, but they're not. So there's some brief outline of our presentation, a little background on what this p-value hacking is all about, and a little bit on peer review and replication, and then a presentation on the one remedy that's probably gaining some steam is the Bayes factor, and then conclusions in summary. But the paper has a bit more details on things, so because of time constraints, I can't cover everything. But the p-value is commonly used to establish statistical significance, as we all kind of know, and it's often kind of misunderstood and perhaps even misused. And I think a great discussion on this, and even looking at standard errors and all that other jazz, is McCloskey and Ziliak. And they kind of talk about all this and some of the issues surrounding it and some of their assessment of prior research looking at this topic and how these transpired and how they misinterpreted their work and the earlier work, I should say. And then we all know that the null hypothesis is going to be the default assumption, but or the evidence that's going to be presenting would not be meaningful. But the alternative hypothesis is saying that the evidence would be meaningful. So we kind of work backwards and we calculate the probability of null hypothesis using the true given the presented evidence. So how does the p-value actually come about? It's actually not a very old idea, believe it or not. So I have a little more extensive discussion on this in the draft paper. So the extensive use of p-value by researchers is basically attributed to R.A. Fisher in statistics. He did so in the late 1920s. Then Neyman and Pearson came along in the 1930s, and they kind of formalized this hypothesis testing with a priori assertions by adding, hey, let's have an alternative hypothesis that's mutually exclusive from the null hypothesis. And so they basically say, oh, let's have this level of significance. And then, alpha is 0.05 or whatever you set it to be. And then the researcher would calculate some p-value based on the test statistic and compare it to that level of significance. Whereas we all know if the p-value is less, well, very small to the level of significance, we say it's significant. And if it's greater than that, it's not significant. So that's what we basically kind of know and learned. But it goes back to, how do we know what we know and how do we know that all this is correct? How do we know that this p-value thing attributed to the standard error and all this kind of thing? How do we know that it is doing what it's supposed to do? Well, let's suppose you're an attorney. You're defending two clients accused of robbing a store and shooting the clerk. Well, you have the evidence against them. It's based on what people saw. But nowadays, you have people with cell phones all the time with video. So people can actually record all this criminal activity. So let's ignore all that. Under the presumption of innocence, how is it likely for these witnesses to incorrectly identify the suspect? It's not impossible, just improbable. It could be 1 in a million chance of bad luck. There's 1 in a million chances what we call the p-value. It's, some probability of saying, hey, let's find some observed evidence when the null is true. So the lower the p-value, the greater the significance of the evidence. So it's important here not to note that the confidence level does not mean probability of guilt. It's just saying, hey, let's have this assessment of this evidence. Consider this crime scene, and investigators found the defendant's DNA and fingerprint. If the defendant did not commit the crime, it would be very improbable that such evidence would be found at the crime scene. There, the probability or the p-value could be very low, and the confidence level could be very high. But what if we later find out that we go to the defendant's house and there was some evidence? All of a sudden, the evidence is much more plausible. It would be weird if we did not find any evidence in that suspect's own home. So the p-value of evidence goes up, and then the confidence level goes down. So so enough on criminal behavioral stuff. So the power p-value is used in economic, social science, and educational research. The researchers, we try to act like prosecutors, as I described in the following preceding example. We're trying to prove whether something exists or not. So our null always says something doesn't exist, and our alternative says, yes, it does exist. So we want to be able to use a precise measure of the p-value to decide whether it's significant enough to add to the larger body of evidence. And why do we do that? Because editors of journals are looking for that. So, and we always assume that we reject the null hypothesis is significant, and we leave it at that. So one time I was involved in a psychological analysis review, and the researchers were very, very upset. And she's a psychologist. Her p-value is like 0.025, not 0.00. She was a bit angry that it was not that small. And she's like, I said, but you have to look at the implications of this, and I was going on about that. And she looked at me like I was crazy. And so, I don't know, I think she was just in a bad mood that I think her p-value wasn't that small. And I told her, I said, you gotta look at other things besides that. So as Nuzo was saying a long time ago, p-value does not give you that. It can never give you that. So you can think of the p-value as some type of index of surprise if you want to look at it that way. So how surprising would your results be if your hypothesis was false? That becomes significant. And like that psychological study that I looked at for that person, for some reason, I think she should be banned by APA. I mean, I don't think she quite guessed what she was trying to do. But peer review, we could also actually use that as a way of determining whether or not something is working or not. So there was a session at a regional economics conference, and the researcher again was upset. The p-value for these variables were greater than 0.05. And then he basically was very visibly upset. And he's like, how am I going to get this damn p-value down below 0.05? Everyone just sat there like, what are we going to say? But so obtaining that is very important. And as we all kind of know in the funny world of economics, sometimes we can get more data, sometimes you just can't get it. And then so just play with the numbers a little bit, or maybe change the regression or something crazy to hope that that p-value gets smaller. So what are some of the alternatives to p-value? And so one, it would be typically we get p-value to look at the study design, the effect size, use of confidence intervals, and so on. But we want to be able to develop a better understanding of what we're trying to do and get some truth of the result. So we could use like a Bayesian approach. And that's been kind of rising in popularity. And so, remember all that Bayesian or that Bayes theorem stuff you learned in probability class, it's kind of based on that kind of framework. And that you can go, Johnson 2013 kind of elaborates on going from the Bayes theorem to the Bayes factor if you're kind of interested in how it goes from one to the other. So the Bayesian approach is kind of like a hypothesis testing. It's comparative in nature. The approach that I was describing, or that we're all accustomed to, is the frequentist approach. Here's a number, compare it to the number, and make a decision. But Bayesian is kind of different. So the likelihood of data is considered under both the null and the alternative hypothesis. And then we compare all the probability to some Bayes factor. And probably some of you are sitting there thinking, how do you actually estimate all these kinds of crazy things? It's not that hard. So the alternative of p-values is just to use this Bayesian approach. So what is it, the Bayes factor thing? Well, here's a little formula here, since we all like to look at formulas and things like that. So it's the likelihood of the data fitting under the null hypothesis with the likelihood of fitting under the alternative hypothesis. So it looks something like that. And so why do we use it? So Reagan markers and others suggest, the p-value is going to depend on some hypothetical data. The Bayesian approach only considers the observed data. How does it relate to the null and alternative? That's what we're interested in. So the Bayesian approach is not altered by stopping any measurement or anything like that. You have your data, you look at it, and you determine how to actually calculate it. So as you kind of know from Bayesian econometrics, there's the priors and the posteriors. And then everyone kind of knows that with the priors, that can be very subjective and kind of very difficult to estimate, as we kind of know. So basically, but you don't have to worry about too much of that with the Bayesian approach here, because it's just ratios of probability and seeing which is going to happen. In favor of the alternative, you don't have to worry about the sample size or anything like that. So it's kind of beautiful. But here's an equation to look at the Bayes factor. And the beautiful thing is, even though it looks kind of like, how do you actually estimate all this stuff given my data? You can just actually calculate the BICs using the traditional software that we all like to use. SAS, R, EView, Stata, whatever your favorite thing is. And you can actually determine the Bayes factor by using these BICs. So you can actually have it in the output, and you can actually go and proceed to estimate that. And then the preceding equation uses the difference between the two BICs for the null and alternative hypothesis. So you can just sit and use your regular old software to actually calculate everything. And then everyone will be happy. And then you have to be able to interpret the result. And hopefully by the interpretation of the result, that it will give you some meaningful insights on what's actually what you're trying to show. You don't have to be like the regional science conference that I went to and say, how do you get these damn p-values down? You don't have to worry about that anymore. So what are some of the advantages? Well, it's not just a measure of how unlikely the null hypothesis is, but how likely is it compared to the alternative. It's just simply saying, another way of saying it's unlikely there's no relationship between these variables, but what you're really saying is the alternative model is considerably better than the null, and I have the probabilities to show that. So it allows for the inclusion of a statement if the results are much more likely of the data to occur, if the null is true, then you can compare it to alternative hypothesis to see if it's true. But if we assume that the prior odds, I was talking about the prior probabilities earlier, is assumed to be 1, you can just simply take the inverse to allow the likelihood of the alternative hypothesis compared to some null. So I know I'm running out of time. So you interpret the p-values and you look at the value of the truth that is known. Researchers use p-values, but we ignore the measure of probability showing that whether the hypothesis is true or not. So the p-values do not indicate the probability that the data were produced by random chance alone. So we're kind of in the paper, I elaborate in a little more detail about the whole Bayes thing. And then the Bayes factor includes information about similar ideas to regular old p-value and allows you to make better statistical inference about the evidence of your experiment or your research rather. So the BIC approximation is a rough estimate. It's kind of like a very simple way to gain the benefits of the Bayes factor without having to do additional statistical work or additional statistical programs to actually estimate the probability. And that is it. And my heat is still off.
Great, thank you, Brian. You're right on time there. Let's see.
I'll share mine.
Go on to our Discussant, Rolando Santos.
Yes.
Take it over.
Okay. So let me share my screen. Can you see my screen?
Yes.
Okay, good. Let's see, where am I? Okay, so I will do a summary of what Brian did. Okay, first of all, thank you very much for inviting me to this conference. Okay, and I really enjoy the paper. Okay, because it gives me a different perspective of how to target. Okay, the significance of a given study that sometimes I overlook that. Okay, and it also gave me a new methodology of looking at, testing the significance of a particular, hypothesis. And just to give you an overview, okay, so what Brian did was simply provide an alternative to p-values, okay, such as in this paper. Actually, I extended to what Brian talked about, and that is Bayes factor and meta-analysis. So basically, he wants to explain or relate the quantitative approaches, okay, of how researchers, okay, seek to reasonably be confident in terms of providing, how do you call this, econometric evidences to improve policy making. And that's basically what his main objective is. And how the model would approaches fit the framework of the significance versus statistical significance. So he started his discussion with the pros and cons of p-values. So the first one, he talked about some importance of that number, which is 0.05. And if p-value is less than some significance, economic researchers will then believe that alternative hypotheses can become true. The cons of it is that the p-value depends on hypothetical data. That is to say that something distribution represents many iterations of some experiment, okay, which means that it does not really guarantee some form of statistical evidence. So his alternative is basically the Bayes factor, okay, which is the ratio that contrasts the likelihood of the data fitting under both the null and alternative hypothesis. But the only drawback of Bayes factor is that it requires a prior. And the prior can be very subjective, okay? It could be problematic in the sense that, you know, it all depends on what the researcher may assume what that prior is. Okay, so some priors may be different from other studies versus another. I think he stopped here, but you know, the paper itself included another version, which is the meta-analysis, which, you know, I spent more time on it because, you know, I think, you know, from a health perspective, I think this has more relevance than simply looking at beta. How do you call this? Bayesian, was this the Bayes factor? So in meta-analysis, I think this is more relevant in health economics because, you know, it performs an evaluation of a large subset of studies from research area that include all biases into account. So what he did talk about is the distinction between fixed versus random effects. And in the case of fixed effects, okay, you assume that all the information there are pretty much identical as opposed to random when you have a heterogeneous research. Now, just to give you an overall assessment of what the paper is all about. I mean, overall, I think the paper is very good, okay, because I learned a lot, okay, in terms of what other alternatives I can use, okay, in order to test my hypothesis. Okay, and I mean, comparing beta versus meta-analysis, okay, beta has a better, how do you call this, way of testing the hypothesis because it gives you a comparison between the null and alternative hypothesis. However, you know, I think meta-analysis, on the other hand, has more weight into it, okay? Why? Because it gives you an idea in terms of your sample size, okay? And that is whether your sample size are homogeneous versus heterogeneous, especially, you know, when you think about, how do you call this, health economics, like testing drugs, okay? So it all depends on the kind of, how do you call this, resources that you use in order to implement the study. I mean, you cannot just assume that all the studies are homogeneous or identical, because especially, you know, when you're dealing with drugs, sometimes, you know, your sample size may be different. Okay, small sample size may be different from large sample size. So there's a wide variation, okay, in probably in your, how do you call this, differences in the results, which at some point, I think, you know, meta-analysis could have more impact than that as compared to Bayes. With this in mind, you know, I mean, I guess it all depends, okay, on the study that you're dealing with, okay, that is, you know, it may be appropriate for some studies, okay, but for other studies, especially for small sample size, I still believe that p-values has its merit, okay, but again, in this case, I mean, obviously you have to start from somewhere else. If your sample size is small, then I think p-values is more relevance, okay? And then, you know, if you are mixing different studies, such as, you know, large versus small sample size, then, you know, you can go ahead and look at some other alternative. That's just basically my comment. Thank you so much.
Thank you, Rolando. Appreciate that. We are right on time, so I'll open things up now. I guess first, if any of the presenters would like to respond to the comments they've received, we'll do that first, and then open things up for any other questions people have. You don't.
I will just briefly respond to Stephen. I just want to thank him for the very valuable comments and feedback. I found it very helpful. And I do like the idea of separating out. We have a lot of work we can, the data, we didn't get as high a response rate, but there are things we can do with the data that would separate out the psychological effects and then the cost benefit from an econ perspective. So that was nice feedback. Thank you for that. And in terms of the small sample size and what we present today, we actually did a ton of robustness analysis and looked at this so many different ways that what we reported today was after a bunch of that kind of analysis that was the most robust findings, but I agree it's weak because of the small sample size. Thank you.
Okay, great, thank you. Anyone else like to respond? No, you don't need to, but if you'd like to.
Really quickly, I also wanted to say thank you so much, Professor Amula, for making these excellent comments on the part that we have to look into the population. I really also think that this is one of these new developments and really exciting developments that might come out of the crisis, is that economics is really experiencing an opening up of aggregate functions and aggregate data sets, with the long haulers being 70 to 75% female, but also middle-age populations. We currently will hopefully see more and more law and economics extensions where economics is really informed about disparate impact analysis from the legal side. On the other hand, I do hope that especially governmental economists can also really imbue a long-term view, a beauty in really formalizing models and discounting over time what this means for society. So have the grand prospect, but also be able to zoom in and see the effect of large-scale external shocks, what it means for different population groups, all in order not to show the differences between groups, but really all driven by these ethics of inclusion, that you make the case that growth has to be inclusive. Recently, there was this news piece out that the US might pass on its drive in excellence in sciences, but this will go more for a renaissance of really also thinking about growth being inclusive. And it's not only about putting your money into excellence, but also to think about how to embrace different stakeholders and really democratize ideas of excellence of science and really opening it up for different groups.
Great, thank you, Julia. Any other presenters have comments? All right, I think we'll open it up for questions then from the audience or the other participants. Anybody have questions or for discussion or for any of the presenters?
Hello, I do.
Okay, Amelie.
Hi. So it's a point slash comments slash question from an uneducated attendant of this session, because I really don't know much about these health issues. One is to Julia for your paper on the long haulers. From what I saw, especially in the beginning of the slides, the error was so huge that, again, as an ignorant person, I don't know how much to believe what you're trying to do. If the long haulers are between 5 and 50%, or 7 and 70 or some kind of, really weird ranges. I really don't know what to believe about this data. So maybe, people should probably pinpoint the data better, or find, even for a smaller data set, give us better estimates and then try to make a point. And my second question is to Deb and Lorraine's paper. It was fantastic when you talked about compassion burnout. I think I really see my doctor in there. I always wonder why she's so detached and ugly. What about, from the point of view of the patient? So can the patient report that? I mean, can others in the group? I mean, you say it's multidisciplinary, interdisciplinary, all that I understand, but this is probably voluntary or,
Yes.
So in other words, yeah.
So you would have to give everyone a survey to kind of get an idea of where they stand as far as compassion fatigue goes between the burnout and the satisfaction. Currently now with staffing shortages and everybody just trying to get by, I think this is something we'll probably be doing kind of in the future. Patients, unless they have a bad experience with someone and they would go home and start thinking, well, maybe I am a little burnt, I didn't like my response to them, they might then seek some help. There's also cold lavender in the hospitals now. So if you or someone, you decide that you've seen too much death or seen too much and you need some emotional support, they do have some things in place in the hospital now to, and anyone can call it, to support the staff. Not so much the patients. Mm-hmm.
But these questionnaires appear voluntary. Does the hospital make them take this test?
No, it's just a tool that's available.
So when my doctor tells me, it pretty much, I mean, she didn't say it, but she said, I have seen so much worse, when I have seen people dying and you are like, 6 months from dying, I don't care about you. That's basically what she said. Can the other team, can other team members, because they're usually more than one person in the room?
Well, another team member can call a cold lavender in the hospital, but I would certainly report if your physician said that to you. I would change doctors, and I think I would report that to the practice if they're more than one practice. That's disturbing. This is more to capture physicians clearly, but also nurses, I think therapists, and it does impact their personal life too. And that's what, the compassion fatigue tool goes into some of those things as well. Get another physician. You need someone who is empathetic and listening to what your needs are.
So I think it's a tough question, Emily, right? Because you're asking from the patient perspective, and what I think everything we do is from the patient perspective, in that if you have burned out physicians, exactly that happens, what you just described. And it really inhibits a good relationship with the doctor and the production of health, which is what this is all about. I think what we're facing right now with the pandemic is such severe shortages that even a physician who should not be practicing right now is going to be, I suspect it's at the point where they look the other way. If the team members notice this, it probably is just negative contagion, but at the same time, people are being told to go back to work a few days after they've gotten Omicron because they're needed. So I don't think I'm helping the situation, other than this is a real problem. But at least the first step is if there is this code lavender kind of system in place to try to detect it. And I do think that patients, as Lorraine said, it would be a good idea to report it to the organization that you're seeing, that this was not a good experience and you want another doctor, reveal preference kind of thing.
And as part of patient-centered medical home, we have sent out surveys to our patient population, and we have them rate the doctors, the visits, the front office staff, everything. And so if we do get somebody did rate the doctor, said they were rude to them or something, we do address all those issues. So that should be reported so that organization can take care of those kind of things. It's not a perfect system, but they do want that kind of feedback, because 5 years from now, when this is hopefully behind us, or hopefully sooner, they still want to, it's customer service skills. They still want you to be coming back. So that's how we handled it.
Great. Other questions or comments here? We have about 10 more minutes if we have more thoughts.
Sorry, Julia didn't have a chance to respond to me.
Yes, thank you so much. It's an excellent comment. The data is currently really forming in front of our eyes, and the problem there is that first the definition of long haul is different. So some accounted for people who have longer than 6 weeks symptoms, and others say it starts from longer than 12 weeks. So first you have that, and then you potentially have within this broad category of long haulers 3 different subcategories: the organ damage, the viral load that's lurking, and the immune system over response. And I think the next step would be to really weed these 3 categories out. Some see overlapping symptoms, but really once you start weeding these out, you will have also the gateway how to cure. So the organ damage will have transplant, the viral load will have good medication, and immune system, that's really these lifestyle changes where people start living more in harmony with nature, and stress levels have to come down. And once you have that, I think you will be clearer to see who is affected and how the data really shapes. But you can already right now say this is really happening online in social media. So the social media informed scientists were the first ones who really went to the traditional media and said, look, there's something going on. No one really wants to go in hospitals with mild symptoms or symptoms that come and go and do not hurt that much. But they detected this, and they blew a whistle on that. But you also currently, when you think of the dimensions, then it becomes clear that this is really a pandemic within a pandemic. With the people who are currently in the emergency units, it's a life-death decision, which is of course way higher risk. But when you discount how a long hauler, if a child right now gets set into a trajectory and has 60 years ahead of lifetime quality being degraded, then it really, when you start discounting the longness of this disease and the possibility, then it also opens eyes that this is really a pandemic within the pandemic. And one final comment, you really have to also give credit in the US. I think there is the starkest movement of these long haulers really shouting out. You have people from other countries saying that they are so grateful that Facebook exists, that their countries are not recognizing this issue. And in the US, you do seem to have very outspoken people, and the social media being there. The caveat of this is definitely privacy issues. When people are patients, are in pain, who's really protecting them? Are they secured on social media from advertisement, things like this? So I hope to see more regulation in this corner also coming. And the final remark, law and economics seems to be really, you have to have both at hand. Economics with thinking about externalities and discounting, but also the legal side, the US at the forefront, the Biden administration really also embracing long haulers under disability protection.
All right, thank you. Anybody else have any other questions or comments?
I just wanted to ask Areerat some questions about the the diabetes? Would that be okay? Do we have time for me?
Sure. Yes.
So I just have a question. So it was an ICU patients, correct?
Yes.
So I don't know a lot about machine learning, but I guess what I'm trying to see is when they're searching, were they looking for like an ICD-10 code that said type 2 diabetes? Or were they just looking for elevated blood sugars? Because in an ICU setting, there's a lot of reasons why you would have elevated blood sugars, infection and stress hormones and so forth. So did they get the diagnosis of diabetes, or was it, I guess I just want to see how they did that. How did that machine learn, the machine learning, what diagnosis did they pull out?
Oh, yes, machine learning try to diagnose whether someone has diabetes based on the information. And yeah, I did talk with some of the health care providers, and usually they said in that setting, the ICU, usually nobody have time to test anything. They have to treat the symptom. They have to treat what happened in front of them. But having diabetes could be, a factor for treating differently. So what would be the good way to try to guess that, try to estimate that? And that's when they want machine learning to come in. Because the data, especially if people come from ER, then they would not have any medical histories to really assist the doctor to determine that.
So the goal of it would be to have that information before they hit the ICU.
When they come to, that's it already in the ICU unit. Yes, but they don't have it.
And just so you know, they do tie, different BMIs with different ethnicities. So there are trends for diabetes in different ethnicities. So especially type 2 is related to BMI. So this would be a good interdisciplinary project. I don't know what your team is built on, but I just think this would be a fascinating interdisciplinary, have the diabetologists, endocrinologists, and everyone involved in this. I think this would be a good project.
Thank you. Yeah, and I actually talked with someone, and that when they say different ethnicity, maybe it should have different criteria. For example, BMI of Asian might be different from BMI of Caucasian, where smaller BMI Asian might have already diabetes with the smaller BMI.
Right, that's true. That's what we find. And then, the incidence of diabetes in the American Indian population is very high as well. And there are other where we have less access to good food. Those sections also tend to have higher BMIs.
Thank you. So in a way, it's not. But go ahead.
I wanted to interject in this discussion, and I know in Washington D.C., all hospitals exchange information, or wherever. If you are a patient at Georgetown and then you end up at George Washington, they have your records. And I wonder if that would be, something you could also look at, because sometimes, the record exists when they arrive in the ER, even if they are from another hospital, they may have the record.
Yeah, thanks. In this case, it's not the state-of-the-art hospital. They don't have that. Then they don't even have the funds that maybe to have good system of collecting patients' data. And so how would we do with that when they don't have good system to collect data, and they have like you could see a lot missing data. And so how would they do with that? But I would not just trust on machine learning only. I mean, in my thinking, even with all these experiment going on, I keep going back to domain experts to get idea, to bring it back, to work on that. Mm.
All right, so I think we're ready to wrap up unless anyone else has a last comment or question. All right, well, I'd like to thank everyone. I'd like to thank all the presenters, all the discussants, and everyone else that that joined our session. I think it was a very interesting, timely, and productive session. So thank all of you, and hopefully I will see you in person someday. But
Definitely.
bye.
Thanks, Seth. Thanks,
Seth.
everybody.
Thanks, Steve.
Bye.
Bye, everyone.
You all.
Thank you.
Bye.
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 Thanks.